So first, I have a case of hyperkalemia, rhabdomyolysis, and isolated infraspinatus compartment syndrome in an IV drug user. I have no disclosures. So in this case, we were going to recognize the role of nephrology in diagnosing compartment syndrome, describe the unique presentation and diagnosis of infraspinatus compartment syndrome, and emphasize the importance of early recognition and intervention in compartment syndrome. So this is a 46-year-old male with a history of habitual cocaine abuse who was found unresponsive by a friend. He was given Narcan in the field and brought to the ED. And on arrival, he reported falling on his shoulder and some shoulder pain. Like I said, he was given some intranasal Narcan in the field, after which he immediately became more responsive. He reported habitual cocaine and marijuana use several times per week for both, but he had a 17-year history of opiate abstinence, and on the night prior to presentation, he relapsed and injected a bag of heroin, became unresponsive, and had unknown downtime. He vaguely recalled falling on his left shoulder, but was unsure how long he remained in that position. And again, the only thing he was complaining of was just pain in that shoulder. Past medical history, not overly exciting: asthma, hypertension, anxiety, and some polysubstance abuse. He was not on any home medications. He had no significant family history, including kidney disease. He lived with a friend and worked part-time in a group home. He previously lived in a different state where his PCP's office was located, so he had no local follow-up or care. He admitted to using cocaine and marijuana frequently. Like I said, on the evening prior to admission, used heroin and fentanyl after a 17-year hiatus. He did drink Bailey's in his coffee almost all day, every day, and stated that he was not interested in any rehab programs at the time. So the ED documented this physical exam. It was fairly unremarkable. He had some mild auditory wheezing, was given some oxygen just mostly for comfort. They didn't remark on any kind of tense compartments or anything like that. Their musculoskeletal exam just said he had limited active range of motion in his left shoulder that they felt was secondary to pain. So in the ED, he was hypotensive on arrival with SBP in the low 80s. I guess initially he was a little hypoxic, and they were giving him some oxygen. POCUS was significant for an overall global reduction in cardiac function with a collapsed IVC. He had some B lines that were more pronounced on the left. Chest x-ray showed maybe some kind of pneumonia, and he was given 2 liters of IV fluids with an improvement in his BP. This is the first set of labs we got back with a few exciting ones. The potassium of 8.4, it's a big one. Creatinine of 3.42, again with no history of any prior renal disease. Lactate of 7.8, CPK approaching 60,000. And as we expected, UTOX positive for cannabis, cocaine, and benzos. So in the ED, when they got the labs back, we were consulted based on those initial lab reports. In the meantime, this was very early in the morning, so things like towards the tail end of night shift. He was temporized with insulin, calcium, dextrose, low calma, and he had an improvement in his potassium to 5.6. And 2.5 hours later, a repeat potassium was back up to 7.5. It was right around the time that the repeat potassium came back that I got to him. Given the rapidity of the relapse and the almost 2-point change in it, I suspected that something else may be going on, even though they assured me he did not have compartment syndrome based on their exam. But I went in and his arms and legs were fine. I even checked his glutes because that often gets missed. Those were fine. But because he had reported that he fell on his shoulder, I asked him to see it, and he had very long hair, and he asked me to help him put his hair up because he couldn't lift his arm. So I moved his gown out of the way. And there was a very tense, firm, swollen area on his, just below his scapula on the left side. So I ordered a bicarb drip, and I asked for a trauma surgery consult out of concern for compartment syndrome that, based on its anatomic location, we felt was probably the infraspinatus muscle. And I figured that he would probably need dialysis, but I wanted to consult with trauma surgery for planning and timing purposes in case they decided to take him to the OR. So this is what his shoulder looked like. And you can kind of see, I don't know if the mouse will show you it, no. So just below like kind of his armpit, and there's like, it's hard to see on the picture, but there was like, it was bulging and it was very, very tense. So the trauma surgery consult came in. They said that he had rhabdomyolysis with acute renal failure and refractory hyperkalemia. And the source, based off of their physical exam, was compartment syndrome, what they felt was the deltoid. And they decided to take him to the operating room for a fasciotomy. 3 out of 4 of his extremities were not exciting on the exam, but based on their left upper extremity exam, they said that he had uniform swelling over the superior aspect extending to the posterior of the aspect of the shoulder. There was some non-blanching erythema extending to the top, down the medial border of the scapula. He had difficulty with abduction past 30 degrees and significant pain with palpation, and it was pain that was out of proportion with physical exam, but the compartments of his forearm and upper arm were soft and compressible with both motor and vascular intact. So at this point, the verdict was that trauma surgery was going to take him to the OR for a fasciotomy, but before that, in order to please our anesthesia colleagues, we brought him to the dialysis suite, and I placed a temporary line, gave him some urgent dialysis, and then he went right to the OR. So in the OR, they reported that there was they opened him up, and there was an area bulging in the skin that was more medial anatomically than previously thought. And they dissected down to the fascia and identified a discolored muscle underneath, which appeared attached to the scapula. The muscle was dusky and purple, and it had no reaction to the bovie electrocautery. Based on its anatomical location and attachment, it appeared to be the infraspinatus muscle. There is an intra-op picture coming next for anyone who doesn't like gross stuff, by the way. So this is what it looked like. This is a picture from the OR, so you can see how dusky and discolored that muscle was. And he probably went to the OR sometime around like noon-ish. So final diagnoses, severe rhabdomyolysis causing infraspinatus compartment syndrome, and an acute kidney injury from dense pigment-induced ATN. Our final treatment was supportive care with IV fluids and subsequently hemodialysis, a fasciotomy for compartment syndrome, and he remained on dialysis for approximately a week, and then eventually was able to come off and was discharged home off of dialysis. So I think, I don't, sorry, I don't know how this works. So here's a pop quiz. So of the following sites, rank them from the site of most common to least common compartment syndrome following prolonged downtime in a drug overdose. Does it start working on its own?
Yeah.
Okay.
When people
Okay.
answer, it'll start going.
Doing good. Is everyone good? Okay, so lower extremities, legs and thighs is by far the most common, followed by glutes. Third is forearms, actually. Fourth is upper arm, and fifth is paraspinal muscles. So these are the 5 most common sites of compartment syndrome after prolonged downtime with a drug overdose. Obviously, infraspinatus compartment syndrome is a fairly rare complication, but a significant cause of rhabdomyolysis and pigment-induced ATN, which in this case led to dialysis dependence. And a big highlight here is that the importance of a thorough physical exam cannot be overstated because it's essential to prevent a misdiagnosis of compartment syndrome. As I said, he had been examined by no less than 2 to 3 people in the ED, as well as the admitting hospitalist before I got there, and everyone missed it. A big tip for me was the refractory hyperkalemia and the pain out of proportion with the exam. Infraspinatus compartment syndrome is obviously uncommon with very limited cases documented in literature. I really only found one other case of it that was following a shoulder arthroscopy where there was a massive fluid extravasation that led to rhabdo and anuric renal failure, but it wasn't isolated infraspinatus. It also included the deltoid and supraspinatus muscles as well. And it's generally thought that these compartments have more pliable fascia and are less prone to compartment syndrome, which is part of the reason why these 3 compartments are less prone overall to compartment syndrome. Nephrology plays a pivotal role in identifying compartment syndrome in some of these cases, especially where, like I said, hyperkalemia and rhabdo are disproportionate to the injury. A high percentage of patients with traumatic compartment syndrome develop rhabdo, and those with rhabdo have a higher likelihood of developing AKI, which highlights the need for, again, early diagnosis, more frequent monitoring, and aggressive treatment to prevent these complications. Prompt recognition of compartment syndrome is crucial to preserve muscle integrity and prevent damage, which can occur in as little as 8 hours, and I've seen it occur in even less. And the American College of Emergency Physicians emphasizes that early and aggressive fluid resuscitation is the main intervention for preventing and treating AKI and rhabdo, and the use of bicarb, mannitol, and loop diuretics lacks strong evidence for improved outcome and should be considered on a case-by-case basis. And this gentleman, we decided to give him, so he needed further fluid resuscitation, so we switched him from, I believe the ER gave him LR, and we switched him to bicarb drip while we were waiting for dialysis. Some takeaways here. Infraspinatus compartment syndrome is a rare cause of rhabdo and pigment-induced ATN, leading to dialysis dependence. Nephrology plays a pivotal role in identifying compartment syndrome, particularly in cases where hyperkalemia and rhabdo are disproportionate to the injury. And prompt recognition through thorough physical exam and clinical suspicion is essential to preserve muscle integrity and prevent irreversible damage.
We have a question that was submitted.
Okay.
Oh. Did they have you dialyze for hyperkalemia, rhabdo, or both?
So it was felt that we were going to have to dialyze this gentleman anyway. He had rapidly progressed towards anuria over the several hours of this whole sequelae of workup. And it was thought that we were going to have to dialyze him anyway, especially due to the refractory nature of his hyperkalemia and the rapidity at which it rebound. So we were dialyzing for both anuric renal failure and hyperkalemia, but we probably moved a little quicker than we would have otherwise because he needed it to go to the OR.
Okay. And that was a great presentation. Thank you very much. I got to ask, all right?
Okay.
So what happens to the potassium after dialysis? So fasciotomy occurs. How soon do we dialyze the patient post initial fasciotomy?
So post-initial fasciotomy, so he was dialyzed OR on hospital day 0. We dialyzed him again on hospital day 1. I believe his potassium was in the low 6s on hospital day 1. And then again on day 3, we went on and then he ended up signing out AMA because he had things to do. He had things to do, but he assured me he would be back later that day, which unsurprisingly, he was not. He did come back about 4 days later with, again, anuric renal failure, refractory hyperkalemia. I had to put a second temporary line in him, dialyze him again.
Could I ask
yes.
Much time, but was there a concerned that he was never going to regain mobility in his, whatever this area was. It was on the right? Because I know you didn't follow long enough, but was there concern with the degree of muscle damage there that he was going to be permanently disabled?
So post-operatively, that was a huge concern for trauma surgery based on the degree of muscle damage that they found in the OR. They said that there was virtually no response to Bovie, and they were concerned that he would have a permanent limited range of motion at best. It didn't help that he left, and I didn't include more graphic pictures, but he left. He was left open due to swelling, and they were going to have to take him back to the OR for closure, and he signed out of the hospital AMA with an open wound. I had to pull his dialysis catheter, and I assure you that I spent all of the 15 minutes that I held pressure aggressively lecturing him on how terrible of an idea that was, and he countered me with that he had things to do. He could not tell me further what these things were. He assured me he would be back, and he was, not on the timeline he promised me, but he did come back. Required another line, one more dialysis session, and then he started, entering the polyuric phase of post-ATN, and he got better. And I think then there were issues with housing and dispo, and trauma surgery had to take him to the OR to close him because he left with an open wound. So I think he was in the hospital after the second admission was like 6 or 7 days, something like that, and he left with a creatinine in the low twos. And shockingly didn't come to our office for follow-up post-hospital.
Yeah. So we're going to move on to Anne's second poster presentation, Hyponatremia and Rash in an Immunocompromised Host, the Diagnostic Challenge of Varicella Zoster Encephalitis.
Like she said. I still have no disclosures. So in this case, we will recognize the atypical presentation of varicella zoster in transplant patients, describe the relationship between hyponatremia and varicella zoster encephalitis, and highlight the importance of early diagnosis and treatment in varicella zoster encephalitis. So in this case, we have a 60-year-old male with a history of IgA nephropathy who was status post living unrelated donor renal transplant in 2012, presented to the ED with a complaint of cellulitis secondary to a presumed staph infection on his head, neck, and face. A little more info. Like I said, he was status post living unrelated donor in 2012, as well as 2 prior transplants in 1992 and 1996. He's brought to the ED by his wife out of concerns that the rash was spreading despite already being on oral antibiotics. She had also noted some confusion, and then when the patient came, he reported about 12-hour history of nausea with multiple episodes of vomiting and a progressively worsening headache. Approximately 1 week prior to arrival, he had been hit in the head by a soccer ball, and since then he had been complaining of some pain in the area. A few days after the injury, he went to go see his chiropractor, and he got no relief. Unfortunately, a few days after the chiropractor, he noticed the rash. It started on his forehead and then spread to the top of his head and his face and down his neck. He went to urgent care. They told him it was a staph infection from the chiropractor table, and they sent him home on some oral antibiotics. And then despite that, over another 3 to 4 days, the rash progressively worsened, and his wife noted that he had, like I said, some worsening confusion and some decreased sleep and a poor appetite. In the ED, he denied fever, chest pain, shortness of breath, abdominal pain, diarrhea, constipation, totally compliant with his immunosuppressive regimen. He did endorse some urinary retention and bladder fullness that resolved fully with a Foley insertion. He did say he felt some general fogginess and confusion, but couldn't specify other than that. And obviously the rash was his main concern that had been spreading down his arms and his back. More medical history. So current baseline creatinine is 1.1 to 1.3 with that transplant from 2012. 2 prior transplants in 92 and 96. Hypertension, anxiety, osteoarthritis. Here's a med list, and his immunosuppressive regimen for that transplant was TAC, PRED, and mycophenolate. Very unexciting guy here. He's married, lives at home with his wife and dog, no recent travel, has 2 adult children, works as the athletics director at a local private high school, which is how he got hit in the head with a soccer ball. Never a smoker, occasional social drinker, never any illicit drug use, and he feels safe in his home. So he was very pleasant, calm, cooperative. He was answering me in full sentences. All questions were appropriate, but a little confused, a little whiffy at times. Not exciting otherwise. And then the rash was the big one. The rash covered the top of his head. He was bald, so the top of his head, his scalp, his neck, and his face, and it was coming down his arms and his back. And it was crusted plaques on an erythematous base. So in the ED, he was hypertensive with systolic pressure in the 160s, heart rate in the 90s, but he was afebrile. He was satting 100% on room air, denied any chest pain, shortness of breath. He was anxious and a bit confused, and given the altered mental status in an immunocompromised patient specifically, we were going to get a head CT, so he was given some Ativan. And his wife just kept repeating that he just wasn't acting like himself. She couldn't really put her finger on it, but she said, this isn't him. Chest x-ray was normal. The initial head CT showed a trace focal thickening of the left anterior falx measuring 5 millimeters. Some differentials were artifact, trace focal subdural blood products, or a small meningioma. They recommended short-term follow-up, which he did get a few hours later. These are his labs. This was the first round of labs that came back to us. He had a sodium of 120, a serum osmolality of 266, and a urine study showed a urine sodium of 155 and a urine osmolality of 751. This is the rash. It'd be concerning to me too. So hopefully you weren't paying attention to the title, but whoops, I don't know how this works. With all the information currently available, what is your top differential diagnosis? Oh.
Oh, top differential. That's fine. Yeah.
So some good ones on here. I don't know if we can see it. So I saw graft versus host disease, encephalopathy, shingles, MRSA, PTLD, HSV encephalitis. I have no idea. Great, I didn't either. Vasculitis, necrotizing infectious lesions, shingles. These are all great. These were all included in our differential as well. So, workup. We got that repeat CT that they had asked for, and we did CMV testing, some PCR skin swabs for HSV, HHV, and VZV, Parvo B19. We got a skin punch biopsy, and then in the second round of workup, we got a brain MRI and an LP. So while we were doing all of this and collecting all this information, we gave him some hypertonic saline for what we felt was symptomatic hyponatremia, as well as some urea powder, a fluid restriction. And given the ongoing active infection, we held his Myfortic and his prednisone. We gave, it was also felt due to the nature of the rash that it was likely viral. So we started him on oral acyclovir and then converted to IV acyclovir when our suspicion increased. And then some test results started to come back. CMV PCR was negative. Like I said, imaging was all negative for any kind of mass malignancy. The HSV PCR was negative. Parvo is negative. And then all our positives. So we got a brain MRI. It showed meningoencephalitis, suggestive of an atypical meningitis like fungal source, or atypical herpes encephalitis. All of those skin swabs came back, and 2 of them were negative. Varicella zoster was positive. The LP showed varicella zoster virus in his cerebrospinal fluid, and a serum varicella PCR was positive. And then a skin punch biopsy was the last thing to come back, and it showed rare clusters suggestive of viral cytopathic effect, favored to represent a reactive process possibly related to varicella zoster infection. So we were pretty sure we had a diagnosis at this point. So final diagnoses, disseminated varicella zoster infection, zoster encephalitis, and hyponatremia secondary to encephalitis. In terms of treatment, we gave him a 14-day course of IV acyclovir, as well as IV cefazolin for superinfection prophylaxis due to the extent of his lesions. We restarted his oral prednisone at his transplant immunosuppression dose because it was felt that the immunomodulatory effects of the prednisone should be enough to prevent his rejection without also dramatically reducing his ability to fight the infection. And we maintained the fluid restriction until his hyponatremia fully resolved. So outcome was great. He remained on IV acyclovir for 2 weeks per our infectious disease friend recommendations. He achieved a complete resolution of his CNS symptoms, as well as a complete resolution of the hyponatremia. We restarted the Myfortic, which was the last part of his immunosuppressive regimen. He did get an optho exam, which was clear. And he currently he's about 8-9 months out from this, and he's still on oral valcyclovir BID for prophylaxis per ID Rex. And then they said when he hits the 1-year mark, he can get the recombinant shingles vaccine. This case taught us that varicella zoster, or varicella encephalitis, is a rare but serious complication of varicella zoster virus infection, which can result in significant neurological morbidity and mortality, especially in vulnerable populations, right? So infants, elderly, immunocompromised people. Varicella encephalitis is a very rare complication of a varicella infection, occurring in only 0.1 to 0.2% of all varicella cases. That's not just immunosuppressed, that's all varicella cases. And before the introduction of the vaccine, studies reported much higher rates of varicella-related complications, including encephalitis. But since the implementation of widespread vaccination, the incidence of varicella and its complications like encephalitis have decreased significantly in areas with high vaccine coverage. And like in the United States, for example, varicella encephalitis has decreased by more than 90% since the introduction of the vaccine in 1995. And in immunocompromised individuals, they have a higher risk of developing severe neurological complications, including varicella encephalitis, due to their inability to mount an effective immune response to the varicella zoster virus. The clinical course can be severe with a lot of long-term neurologic sequelae, such as cognitive impairment, motor deficits, or epilepsy in some cases. Mortality rates for varicella encephalitis vary, but are generally higher in immunocompromised individuals, especially in the absence of timely diagnosis and treatment. So some key takeaways here for this gentleman. We had early detection and treatment of varicella infections, particularly in the immunocompromised host, are critical to outcomes. A good history taking is also very critical. It was only after multiple rounds of questioning by multiple different providers that we realized that the patient never had varicella as a child. He was never exposed to chickenpox, never had any natural immunity, and by the time the vaccine was developed, which was in 1995, he had already been 3 years into his first transplant, and he was ineligible to receive a live vaccine. So he had no natural or acquired immunity. So when caring for the immunocompromised patient, it's important to have a much broader differential and a much lower threshold for testing and imaging than you would in immunocompetent patients. Like, we can't treat them like normal patients because they don't behave like normal patients, they don't mount the same response, and they're also more prone to superinfections and opportunistic infections. Questions?
So there are 2 questions, but the second one was answered in what you just said. The question was, did the patient have previous exposure, infection, vaccination prior to this presentation? Pre-transplant, he likely had vaccination. So I think that was answered.
Right.
The other question, did he have lesions on top of nose? If yes, that is called Hutchinson's sign. and is a bad sign, can indicate eye or brain involvement?
I don't recall specifically. I know that they were spreading. Yeah, I know that they were spreading down his face. I think I put the oval over his nose though. Yeah, I cut out part of it. It was a much bigger picture, but it had a lot of identifying features in it, so I cut the picture. I don't recall lesions on his nose specifically.
Yeah, but if you see someone that has something on the rash, always look at the tip of their nose, because if the tip of their nose is affected, then you get scared.
Mm-hmm.
Another question came in. How would he be able to receive multiple transplants without a history of HZV without long-term antiviral medications?
Great question. So at the time of his first transplant in 1992, we didn't routinely screen for varicella titers prior to transplant. And like I said, he had never had any natural immunity. He didn't have varicella as a child. And then by the time he had subsequent transplants, the vaccine was developed, but he was already immunocompromised. He had living donors from, the first two transplants were living donations from family members. So he was never on dialysis in between. So he never got off of immunosuppression, so he was ineligible for the vaccine. So, I mean, his first transplant was in 1992. It was a long time ago. We've gotten a little bit smarter since then.
But they wouldn't keep him on Valcheva afterwards, just being on the being on the medications on the TAC road. I guess if the donor is negative, you don't just stay on the Valcheva, even if it's
like prior to the Zoster infection. I mean, so she asked, or go ahead, you can ask. Why wouldn't we treat prophylactically with antivirals prior to an infection, just knowing that he didn't have? And that's a great question. I don't have the answer to that. I don't do infectious disease. I don't routinely do transplant stuff like this, so I don't know. I don't know if it was ever caught, because he, like I said, went from one transplant to another, and prior to his first transplant, he didn't have any immunity. So I think it was felt that maybe he was, I'm not sure.
Just say it was an oversight.
Yeah.
Because that's what it was.
Yeah.
Right? I mean, the result proves the point.
Right. So, in 1992, we didn't check for it. And, now we obviously do. And we encourage vaccination for people who don't have positive titers pre-transplant for this very reason. So.
Yeah, surprisingly, he never had varicella titers.
Yeah.
Yeah. I mean, it was actually very surprising.
Yeah.
Why did he lose his first couple kidneys?
Could you again repeat the question?
Why did he lose his first couple of kidneys? I don't recall. Sorry.
He had them both for quite a long time. They weren't, I think it was just.
Yeah, like 4 or 5 years was the first one. The second one was a little bit longer than that. And then this last one was from 2012, yes.
And then I assume that this was not the soccer ball.
Correct. So the soccer ball.
Was there any change in immunosuppression? Was there a previous infection? Was there anything else that went on in his life? Did he have COVID? What else made him more immunosuppressed to develop a new de novo varicella, or at least we think a de novo varicella infection?
So, I mean, there could have been chicken pox on the soccer ball. I don't know. So like I said, he's an athletic director at a local high school. Presumably all of the children who are either day students or boarders at the school have varicella. I mean, they're young kids now, presumably they've had varicella vaccination as children, but at least have the titers drawn to be students at the school. It's a little unclear where he picked it up. I don't know.
But there was
But
no immunosuppression?
no other immunosuppression, no recent travel, no known exposure. They had no clue where he got it. But the soccer ball was the red herring in this case. People were kind of focused on the hyponatremia and the head injury in the soccer ball. But we got there.
Thank you,
Thank you.
Anne.
Thank you.
Okay, now that the microphone's working, I'm going to go over some housekeeping that I didn't do at the beginning. So I hope most of you have already downloaded the NKF SCM app. If not, please do that. You will need to complete all pre-tests, post-tests, and evaluations. We recommend you do it now, so you don't have to put it off and do it later when you get time. Downloading the app will also allow you to interact with SCM session polling and Q&As. Presentation slides are going to be available. Some of them are already available, some will be downloaded through the course of this week, assuming that the faculty has approved their slides for download. Please share your experiences on social media with the hashtag NKFClinicals. And please, if you are not a member of NKF, the CAP Council, please join. Go to the opening reception tonight. It's in the main expo center.
Yeah, at the NKF booth.
Yep, at the NKF booth. And it starts at 5:15, so come over there. You've got a free drink ticket in your badge, so you use that tonight. And I think that's it for now. Now I'm going to introduce our second poster presenter. This is Violeta Valcheva. She's a nurse practitioner with over 20 years of experience in the nephrology field. From dialysis patient care technician to RN, nurse manager, faculty facility administrator, group facility administrator, and now nurse practitioner. Violeta has contributed greatly to the world of kidney disease, including vascular access making positive impact to the CKD patient population. She currently practices as a nurse practitioner in the Department of Medicine and Nephrology at Edward Hines Jr. VA Hospital outside of Chicago, Illinois. Welcome, Violeta.
Hi everyone, again my name is Violeta and I hope you are enjoying the conference so far. It is an honor for me to be here today to share this quality improvement project, continuous improvement in dialysis vascular access outcomes at our VA dialysis unit, in collaboration with Hines VA Hospital Peripheral Vascular Surgery, Interventional Radiology, and Interventional Nephrology teams. And just wanted to mention, VA is one of the largest integrated healthcare systems in the United States, and I have personally worked in the private sector and at the VA and implemented similar process, continuous improvement process in private sector and at VA. So this quality project is not purely unique to VA, as well as did that in private sector. Okay, we have no financial disclosures. And learning objectives will discuss best demonstrated practices to lower CVC catheter rates that we implemented in our unit. I'm gonna discuss team and patient engagement strategies for lowering CVC rates, and I'm gonna talk about our vascular access surveillance program that we developed and implemented, and that helped us to ensure sustained improvement in CVC rates. And this is the poster. Again, continuous improvement in dialysis vascular access outcomes at VA dialysis unit. So this quality project is about sustained continuous improvement in our CVC greater than 90 days rate in the past 5 to 6 years. Prior to 2019, our CVC greater than 90 days percentage was consistently in the range 30 to 35%, despite having designated vascular access nurses whose role was to coordinate and manage dialysis vascular accesses. The renal dialysis unit CVC rates remained above 30%. Since 2019, several interventions have been implemented that have led to sustained improvement in CVC greater than 90 days rate from 31% in 2018 to less than 10% in 2024. Quick information on demographics of our patient population, and this is about the last 5 to 6 years demographics. The average patient census was 60, 70, fluctuating between 60 to 75. Mostly males, 87% were greater than 60 years of age, 67% African Americans, and 32% white. Comorbidities-wise, about 92% with hypertension and 65% with diabetes. Now I will discuss the first learning objective, best demonstrated practices that helped us lower the CVC rates. So number one thing the new thing that we implemented at the VA was hiring and having a dedicated advanced practice nurse to manage and oversee the dialysis vascular outcomes. Upon review of literature, it says that literature suggests that hemodialysis vascular access coordinators can optimize the vascular access management, increase the numbers of AVFs, and lower CVC rates, providing better cost effectiveness. While suggesting experienced dialysis nurses to be most suitable for that role of the vascular access coordinator manager, literature is not very clear about the academic education, training, and skills required by such role. Additionally, many dialysis providing companies may struggle to hire a designated nurse for the vascular access coordinator role in each unit due to the budget constraints and staffing shortages, as we are all aware of that. And we at the VA have previously had designated RN navigators for many years in that vascular access manager coordinator role. Those nurses had extensive experience in dialysis and vascular access, but despite that, we could not achieve those desired improvements in vascular access rates. Some of the challenges we've had were related to the nurses at the VA system cannot place orders. They cannot execute that provider-level clinical decision-making for the timely referral and maintenance of dialysis accesses. And also, in the VA, there are a lot of barriers in terms that you cannot tell a different department, you need to do this because I want this or it's best for my patient. You have to establish processes in place. And nursing-wise, if you're just an RN, we are also a unionized institution, so you're very limited to what clinical decision-making you can make, and also implementing institutional organizational culture change is very difficult. So that's why probably the nursing team that was covering the vascular access manager at that time, before 2019, had issues with achieving those continuous improvement in vascular access. I was hired in 2019 in the role of vascular access manager because I was told you have a go-getter attitude, you're not afraid, you are strong. Also, I had extensive experience in dialysis in all roles, from patient care technician to group facility administrator, and now nurse practitioner. Also, my APRN level of education, actually, which makes me an expert in the field, it's that master prepared, I'm not a doctorate prepared nurse, but I'm master prepared APRN, and that actually helped me to utilize clinical decision making, transformational leadership skills, evidence-based practice skills, as well as interpersonal skills to identify process barriers at individual, unit, institution, and system levels, as well, not only to identify, because it was very easy for me to identify those gaps, but to propose and implement changes in the VA system. And that was unique about my experience and what I did at the VA to improve the vascular access practices and outcomes and achieve a CVC rate less than 11% for 5 years. So I had to also reorganize and restructure the existing vascular access processes, as well as engage different stakeholders, starting with the patient, dialysis team leadership, interventional radiology, interventional nephrology, vascular surgery, community access centers, hospital leadership, and if you want, the union as well. I used all the resources to help me work on behalf of our nation's heroes. And what my legacy here in this project is, I made the vascular access concept transforming from nobody's job to everybody's job. So the following, I just gonna concentrate on a few things that I implemented, actions to lower CVC rates. So what I did, we created a pre-SRD treatment option clinic that helped us when a patient has eGFR of less than 20, and I get all the referrals from our renal nephrology team, and I meet them in a pre-SRD modality educational clinic, and I follow them in 1 to 2 weeks to when they finalize their modality choice. So, and once they finalize their modality choice, I refer them right away, place a consult, so they get a placement of the respective vascular access. Besides the pre-SRD clinic treatment options and vascular access clinic, I also am serving as a liaison between all the teams in the VA, renal service, vascular, interventional radiology, nephrology, community clinics. I'm also collaborating with the nursing team to provide leadership, guidance, education, and support for monitoring and surveillance of vascular access, identification of abnormal findings, and timely referral for intervention. I'm saying timely, and I'm going to specify what's timely and in a few minutes. I also created and implemented a vascular access navigation workflow, very simple chart, you know, and standard operating procedure for management of routine and urgent arteriovenous interventions with so everybody knows what to do when we have a clotted access, when we have a patient with a catheter, and we know where to refer and who is doing the procedure. So pretty much what I did with the pre-SRD, so when the patient has less than 20% eGFR, I see them in the clinic, I refer them to vascular access team, and they start the process with the creation of the vascular access. Our goal here is to have ideally to have a workable access before initiation of dialysis. If that's not possible and the patient crashes into dialysis with a catheter, I see these patients with a CVC the first week of initiation of dialysis, and I place a consult to vascular surgery, and within 2 weeks we have vein map and evaluation by vascular team, and within a month we have access created and CVC removed. Access created, and within 90 days of dialysis initiation, we have a well-functioning AVF or AV graft, and CVC is removed. That's what we want. And yes, it wasn't easy. There have been struggles and challenges, but we were able, for the most part, to accomplish this. My second learning objective was about team and patient engagement strategies, because in the VA system, and not only in the VA system, but everywhere you have to engage, it starts with the team, frontline workers, and the patient. Vascular access is not a one-person job, it's everybody's job. And so the challenge I had when I went there and started my job in 2019 is that everybody was thinking, I'm going to do the whole thing by myself. But it took me a while until I kind of tried to persuade people that and try to tell them that it's everybody's job, starting with the patient. So what teammate engagement strategies I used? Of course, with the help of the dialysis team management, dialysis unit leadership team, we appointed 4 vascular access champions for each day and each shift. They were the ones monitoring the vascular access outcomes on a day-to-day basis. And then technicians actually volunteered to become our vascular access champions at a technician level, and they were also responsible for the transonic access monitoring. We also met weekly and bi-weekly with all the champs to discuss each patient with a catheter and where if fistulograph need intervention. I also provided monthly services, trainings, presentations to support the dialysis team on vascular access. Those are some of the engagement strategies that I use for the team. For the patient, because we have some very challenging patients that are very resistant. They do not want, they're afraid of needles, they want to stay with the catheter because it's painless, you know. So for those type of patients who want to stay with a catheter and they're refusing cannulations, refusing what's best for them, I work on one-on-one level with them individually. I also, by seeing them in a pre-SRD clinic, I actually was able to discuss one-on-one benefits and risks of each treatment and modalities. And also, I allowed them 1 to 2 weeks to follow up, you know, in a clinic after that. Also, I use motivational interview strategies with patients. Like if a patient likes swimming and he has a catheter, so you have to, you know, get rid of the catheter and get a fistula. So, and also utilize patient peer support, you know, so they can talk to other patients. The last learning objective of this project is our vascular surveillance program, so which we developed. VA did not have any vascular access surveillance program, so I, with the help of the doctors and the leadership team, we've created that program where patients self-monitors, and we teach all patients that, and then the frontline workers, the techs and the nurses, I taught them the look, feel, listen, the 10 seconds arm elevation test, post-augmentation test, all of this. So the frontline team and the patients, they're reporting to the providers, and the providers are the one, especially me, because that's my main responsibility. And I typically can make very quickly the decision once something is reported to me and it's abnormal. I quickly place the order. In less than 60 minutes, patient is navigated to have the procedure or catheter removed or whatever the intervention is needed. As a result of these processes, you know, we have accomplished for the past 5 years catheter rates. We started in the 30s range, and now consistently we are now at 8.33. As of now, maybe we're even lower than that because we had to remove 5 or 6 catheters last week. Thank you so much for being here, listening to my presentation. I hope you can make changes in your practices, that you can accomplish these results as well. Thank you.
Okay, we have a couple questions for you. Mm-hmm. What if eGFR stays stable at 19 for years? Do you think this led to access too early at times if GFR below 20 was the consult criteria?
Yeah, so I have those patients as well, and this is why I've developed the follow-up clinic, and I kind of check with them. When they're less than 20, we do the modality educational pre-SRD session, and then I follow up with them as needed every 2 weeks, so maybe every 3 months, and I communicate a lot with the renal team of doctors, and if they deteriorate, we kind of can speed up the process, but we follow up with them like as needed.
Another question, when you have crash starts, you stated that surgical creation occurs quickly. How did you incentivize your surgeons to prioritize these patients?
Very difficult. Very good question, very difficult. You have to have thick skin. I used all of my resources. I used the union. I used doctors. I used the hospital director to help me. But now they're my friends. We're friends. Very hard.
Could I just make a comment? Not only is it an impressive result, and I congratulate you, I think we're all impressed, but this is perhaps the first quality improvement project that actually succeeded through the pandemic, which to me is uber special. Didn't we able to do this well despite the pandemic, so congratulations.
Thank you.
Thank you.